panel discussions are innovative. It's a great benefit for anyone who takes the time to attend this meeting.
And there was a very practical handling of how to use imaging, how to make interpretation.
Also, it touches various topics, both on the culinary and structural side. Very insightful, exchanging scientific data and results of trials.
And several live cases have been performed to show complex, innovative procedures. Several workshops were
As we move to the next session, we have a live case and a very interesting presentation. So may I invite Dr. Chirag Bhavishi, Dr. Ravinder Rao, Dr. Pradeep Yadav to please join me on the dais. And also may I request Dr. Viveka Kumar, Dr. Maulik Parekh, Dr. Anant Raman, and Dr. Manik Chopra, Dr. Suvir Gupta, Dr. Rajesh Jindal, and Dr. Puneet Verma to please join us on the stage. So, Pradeep, before we start your presentation, can we ask the people at Escorts to show what they are planning? And then we'll go with your presentation. Can we go live? Praveer, can you hear us?
Can you hear us well?
Yeah, so we have Giza Fontos with you and Dr.
Yes.
Praveer Agarwal at Fortis Escorts. We can see you very clearly, and would you like to introduce us? What is your plan for today?
First of all, as you've already told, the Giza is our intensive expert for the case. And my team is Dr. Swati Mahajan, Dr. Jitendra, Dr. Vinal. Anesthesia support is coming from Dr. Astosh and Dr. Abhinav. And our technician is Mr. Mishra. And our nursing staff is Mr. Khuddar, Uma, Mittal, Mutal, and Nisha. And our technicians are Yogesh, Manoj, Praveen, and Jeevan. You know, it's a teamwork. And our cardiographer is Dr. Vivek Kumar. He's really doing a wonderful job in the lab. So let me just introduce Swati. Swati will introduce the case to you.
Hi, good morning, everyone. So the case today we are presenting, can we please go on to the next slide? It's a 69 years old male. He's non-diabetic, non-hypertensive. So he came to us with progressive dyspnea for the past 6 months. Well, when presented to us, he was in acute LVF. He had a PA pressures around 50, and with diuretic therapy, presently he's in NYHA class 2. ECG showed an LVH with strain pattern, a left axis deviation, and a normal sinus rhythm. Echo showed a severe valvular AS, suggestive of a bicuspid calcific aortic valve with a mean gradient of 42 millimeters of mercury. Global LV hypokinesia, a dilated LV with a systolic dimension of 44 millimeter. RVSP at present is 30 millimeters of mercury and an EF of 25 to 30% and normal RV systolic functions. His BMI is 24.6 and the STS score is around 3. Can you go on to the next slide, please? His hemoglobin is around 14 grams per deciliter. Creatinine is 1.34 milligrams per deciliter. SGOT at presentation was 80 and SGPT was 56 and an NT-proBNP of 1800 picograms per ml. Presently, our patient is on dual antiplatelets, a statin, SGLT2 inhibitors, beta blockers, Vimada, and 20 milligrams of Diator and 25 milligrams of eplerenone. Coming on to the treatment issue. So, if we look at the anatomy, as we are suspecting bicuspid valve here, we are having an elliptical annulus. Perimeter derived is around 25.6. At LVOT, we have slightly flared LVOT, which is around 26.7 in its perimeter derived. Sinuses are wide, 33, 37, 34, and STJ junction averages around 31 millimeters. Intercommissural distance at 4 millimeters above the annulus is 28.2. Supraannular perimeter at 5 millimeters, it is around 25 mm. Next, please. So, we've got a bicuspid morphology, a type 1 bicuspid valve with aortopathy. So, ascending aorta is dilated, average is around 40.9. Coronary heights on both the sides are fine, 12.8 on the left side and 13 on the right side. Next, please. So as we said, there's aortopathy, a dilated ascending, and there's a narrowed segment in the arch of aorta just distal to the left subclavian, and a horizontal aorta, the angle about 50 degrees. So as far as the excesses are concerned, so on the right side we have got a lower bifurcation, not tortuous, without any calcification. Left side it is higher take-up, so we went for right femoral excess. Over to you, sir.
Right. So, Dr. Mathur, can we have discussion that what kind of which kind of valve we can use there, and whether we should predilate or not?
Yeah, we can start with the discussion. Firstly, I'll just give my thoughts, and then Ravindra and Pradeep can add to that. Obviously, this is a type 1 bicuspid. The raphase doesn't seem to be calcified as such. So both balloon and self can be done. To me, obviously, it will be a 29 self-expanding valve. It will give a good result at a 27.5 indigenous valve or a 26 Edwards with added volume. So all options will be fine. Ravindra?
So, in my opinion, suppose I was doing this case, I would choose a balloon expandable for two reasons. One, this patient is 69-year-old. We can put in a big size 26 millimeter valve. There's an aortopathy. I just want my valve to be sitting at the annulus, and definitely a future interventions as this patient grows. Now, the only challenge in this particular patient would be that ascending aorta. Otherwise, this raphe is not calcified. This is a left and right fusion. Though the left main is at 10 mm height, the whole valve is going to sit towards the non-coronary side. And the entry in a right and left fusion is more predictable as everything comes close to the, in line with the outer curve of the ascending aorta.
Totally agree. All three valve choices are open, and I usually prefer balloon expandable for bicuspids. This is a great anatomy, big sinuses, so you can easily do a 26 sapien. I don't have much experience with my valve, but I'm sure that can be done safely. Normally I don't predilate, but this one is ascending aorta is dilated. You have stenosis up near the subclavian, so you could predilate this one, but I think it should go fine.
Any other comments from the panels?
Yeah, no, I agree. For bicuspid balloon expandable, I too tend to predilate all the bicuspids. Probably it gives you a better expansion. Here you have a large sinuses, coronary obstruction risk is very low. So that's usually the preference.
Just one comment in such patients, as we are trying to do the valve case for everybody, when we are doing under conscious sedation and we are trying to cross across the annulus, if patient complains of chest pain, that is a very important parameter. That means there is a lot of push happening on the ascending aorta and patients can have an aortic dissection. So a lot of people are doing bicuspid aortic stenosis and dilated aorta. If patient is complaining of chest pain, that means you have to think of another strategy to push the valve across the annulus.
I think one of the other advantages of using a balloon expandable platform is you can actively flex and avoid any contact in the dilated ascending aorta. Even though we can use all three platforms, when you use the self, there is a small chance that it might go and interact with that dilated ascending aorta, and there's a small chance that you can create issues there. So for all purposes, I think as a consensus panelists, we agree this is a good case for a balloon expandable, indigenous valve 27.5, Edwards 26 plus added volume. Any questions, comments? No. Giza?
Yes. What's your comment?
Yes. Finally, we decided to put an Evolus valve, an FX. If you don't mind, we don't remove it from the patient and go back to the balloon expandable. And the reason is that in our practice, the first choice for bicuspid is because of the elliptical shape of the annulus is usually the self-expanding valve in supraannular position, but I fully agree with you, it can be done with each of the currently available valves. We also had some concerns with the dilated aortic root and also with this narrowing below the subclavian, plus this unfavorable anatomy of horizontal bicuspid, very calcified non-coronary cusp. So we went directly with the Lunderquist wire to avoid all the complications from these anatomical features. Do you agree on that, or would you go for Safari?
Yeah, look, there is no randomized trial against Sapien versus Evolute, so there are both school of thoughts. So you're absolutely correct in doing valve that you like. the other concerning feature to me is also the low EF. I think the EF was 25-30 in a horizontal route. So self-expanding sometimes may take a little bit longer to kind of deploy, and sometimes those low EF patients can get hemodynamically unstable, which is why I like just one and done, 10-second pacing, deploy the valve very quickly.
But the good thing is with the low EF, you can get away without pacing too. So,
Was the ECG all right, Giza? Was there any conduction abnormality in the ECG? Because that's one other thing just kind of guides me which valve we'll be using, because there is still like a 20 to 30% chance of bundle branch block when I use a self, and less than 5% with the balloon expandable, and more than 20% with the self expandable. In a EF of 20%, you don't want to give a pacemaker. What is the conduction? Is it normal?
Baseline normal.
Yeah, it's a normal.
Okay. Yeah, over to you. You just tell us what is your setup and how you're doing.
So can we have the next live screen on the table? The puncture was ultrasound guided as usual, and a 14 French sheath. And before that, we wanted to close with Manta. So before we put the sheath in, we have just calibrated that how much depth of Manta is to be there once we are deploying in the end. Next, please. Next, please. So this is the, go back minus, please. So this is a pigtail in the NCC. Minus, please. Can we show the shot? That's a cuspal overlap view. View looks very nice. Then straight forward we went with the crossing. Next, please. It's a AL1 and a straight tip wire. Crossing did not take much time. Then, as Giza was saying, that we already decided that we'll go with the wire defined by him, and he made a special curve on that so that there should not be any problem in the aorta as well as in the LV. Next, please. Next, please. Next, please. So pigtail is sitting nicely in the cavity. Next, please. Next, this is the go back minus. Before that, as a rule, we check the valve. Is it really nicely crimped or not?
Can we see the hemodynamic result of the gradient?
Yes. Can we show the
Pre-gradient, please. Pre-gradient.
Yeah, we can see the fluoroscopy.
Yeah,
We are trying to get the hemodynamic data. Yeah.
is this valve FX or FX plus?
FX?
FX Plus still not available in India. It will be available very soon.
The gradient was around more than 50. Just we are waiting for the slide to come up.
So we have around 6 to 7 minutes more for you to describe.
Okay, no issues. That's good enough.
While they're waiting, I think if I ask Ravinder, obviously, the access choice, 2 femorals or 1 femoral, 1 radial, and next the wire choice, Landequist versus your wire choice.
So wire, we've shifted totally to Safari Extra Small. Totally. Landequist.
Is it coming up?
No.
No?
The axis, I'm still with both side femoral. I
Let them
still go
finish.
both femoral, but there are some cases we have done.
The gradient was coming around 50.
The one
Right,
other thing
so-
I would say is the decision is made outside the lab to treat. Once you cross under general anesthesia, even if your gradient looks less than 15, 20, do not be fooled by that. Do not say the gradient is 10, I'm not going, no. The decision is made outside the lab,
It was
and
there.
there it's
Good.
only the procedure.
Will you do the same?
I have a question.
They had
If this valve had significant or mild moderate AR, would your strategy be different that you will still pre-dilate or what you'll do?
If the patient had moderate AR,
Now,
the patient will tolerate a little bit
on
additional
the
AR
left side,
better
please.
than a patient who doesn't have AR. As Pradeep was alluding, I will dilate it because this non-calcified fibrotic raphe, especially when you're using a self-expanding platform, it does give trouble. So it is better to open that raphe beforehand, before you put a self-expanding.
It does cause
Next
better
slide,
valve
please.
expansion as well.
So this is the position of the wire that these are preferred, so that a nice loop there, so it's not hurting there. And he was guiding us all through.
It was a double curve Landau-Klotz wire, and we tried to make the curve a bit smaller to accommodate better to this LV shape. This is what you can see here. And
Next, please. This is a 20 balloon for predilatation. 22 balloon for predilatation. And a pacing of about 140. We just did that small dilatation. And it was a good waste on that. Next, please. Next, please. Next, please. We are seeing how the valve is going up. Next, please. Next, please.
Can you make it fun?
Yeah.
If you pause here and just show that, it's very crucial when you're using the FX. There's a hat marker which should be on the outer side. The hat marker comes in this view, still on the outer side. When you come to the cusp overlap, it should be center front. It should be seeing us.
Yes.
So that means you have got the commissural alignment. Especially with this kind of anatomy where it's tortuous as well as pseudo-coarctation, the 3 o'clock position may not be right. So you have to make sure in the thoracic aorta that the hat marker is the outer curve. Otherwise, you rotate the catheter there, not in the ascending aorta. That itself,
This
outer
is
curve.
exactly what happened to us. So when we were at 3 o'clock position and went up, it was out of position at the head marker in the outer curve. So we had to adjust a bit. As you can see here, we are perfectly aligned now on the outer curve with the head marker.
Yes.
And when we go to the implant angle, the cusp overlap, the head marker is just in the middle.
Next, please.
Absolutely, yeah.
Like
See that? This is looking fine.
Yeah, it's center front, so it looks good.
And at that point, the pigtail was a bit out, so we went a bit deeper, like 3 millimeters, to have a good marker for us.
Next one, please. Now we started deploying. Next, please.
Ravinder, is your positioning changed compared to Pro Plus to the FX?
So now I start at 0.
We checked it here.
For a bigger valve, smaller
one,
valve,
please.
I would still be 3 mm deeper.
Position looks all right.
Yeah, so previously we used to start at middle of the pigtail with
Next,
the Pro
please.
Plus. Now we keep it exactly where we want it with the FX because the
Now we
FX doesn't
deploy
move.
80%.
It's a very stable
And
valve
then we-
system. It doesn't move at all. You just keep it at the bottom of the pigtail.
Remove the
FX
parallax.
Plus is even better.
Can we have the next, please?
Next one.
So the other advantage with the FX is the depth markers which are there, they are in the commissures. So once
The
it's
position looks
deployed-
all right.
Yeah, it looks very good. It will
have
also
to
tell you the
modify-
commissural alignment you got. 2 dots on the right, 1 on the left. That means you got the commissural alignment.
Right.
Are you happy with this depth of implant and orientation? So this was the point of no recapture. We had 2 markers on the left side of the screen, 1 on the right, and we are a bit below 3 millimeters, I think about 4. That was the point of no recapture, and at that point we decided that we are okay with the depth. Do you agree, or would you change?
You know, it looks good to me. I'd probably go with that because the sort of a poor LV, if you keep sort of moving, capturing, recapturing, it will start giving trouble.
No, this looks good. You can just go to LAO and check with one shot.
Next, please.
This is what happened.
It looks a little bit.
You cannot see exactly where the left cusp is, so repeat it with a bit of more contrast. Next one, please.
So you're probably at 4 millimeters, right? Looks like.
Yes, around 4 millimeters.
Yes, exactly.
So you could afford to come up. Giza, you have 2 minutes. Just show the final deployment, and then we will go to
Okay.
Pradeep's talk and come back to you for the manta closure.
we can do it in 2 minutes. So that was predictable deployment. Maybe it went down like 1 millimeter. So we ended up at about 6 millimeters on the NCC side. Can we get the last one? And this is the final shot. We ended up with 0 PVL. The P gradient was 2 millimeter mercury. With the pressure measurements, the echo showed the mean gradient of 7. So we decided to stop at that point. And if we only have 1 minute left, we can go with the closure with the Manta. Next one, please.
So have you already recorded
This
that?
was after deployment of the Manta device. We checked this metal part of the device that we are against the vessel wall. We checked the ACT. We had to wait a couple of minutes. And let's see the final NGO. Can we go to the last one?
Last one, please.
Yeah.
So I think one of the things with the Manta is you need to assess the depth in the beginning of the procedure. And if you get the depth wrong, then your whole system will be a failure. Ravinder, any comments about the Manta?
Manta is a good device. The other important thing is it should be way above the bifurcation. Just imagine a foot plate which is coming out in the common femoral artery and you pull back. If the puncture is in the common femoral artery but very close to the bifurcation, it will interfere with the successful closure. So mid femoral artery puncture but way above the bifurcation of the common femoral artery.
Thank you. That looks excellent. The hemodynamics looks good. The femoral closure is good. Big applause to the entire team and Giza for being there to guide them. Fantastic.
Thank you.
Thank you, everybody.
Thank you. Thank you, everybody.
Can I ask a question to our surgeon? Just one question.
Thank you.
Sir, suppose this patient comes to your OR and you end up doing aortic valve replacement and leaving the ascending aorta behind. In your follow-up, have you seen progression of the ascending aorta dilatation in such patients? Or do you think replacing the aortic valve in a borderline ascending aorta, the aortic progression dilatation ceases?
I think I would individualize that decision. If this patient, he's quite young, and you rather than just the distance or the diameter, you got to see the other things also. You have to see the angle of the LVA, you have to see how the greater curvature is behaving, how the wall of the aorta is. If those factors give me a chance to replace the ascending aorta, I would do that aggressively in this young guy. But if this were like 75 or something like that, and borderline aorta, then again, I may tilt towards leaving that way rather than making it aggressive enough to replace that aorta. So we have to individualize in borderline cases. Young patient, I will be very, very aggressive because you do not want this ascending aorta to dilate, and they dilate in many patients. And replacing that, redo surgery or something is probably difficult, more difficult. And we put them on risk of dissection. So those things guide us while we operate. And I think here in heart team also, that decision will be very important, what therapy we are looking at.
Yeah, just for the audience, for this case, this was a pure Tavr case because the ascending aorta was only 4.1, 4.2. The reason I want to discuss this question is sometimes we come across patients where the ascending aorta is 4.9, 4.7, 4.8 and 75-year-old. Thank you very much, sir.
Thank you, Prit.
All right, outstanding case, and I know I'm between your lunch and you, so I'll try to be brief. One of the topic that I was given was new platforms for Tavr. And I said, should I just give you like a drill of what 5 new valves are coming, or should I put in something different? And I thought there is no better city to give you this talk, and I'll tell you here is why. It's my disclosures. So let's just, before we get into the valve details, let's just talk about the human connection. What is the relation with India, or specifically to this NCR region? So the Seagull valve is from a company called Mirus. Mirus in Latin means miraculous. This gentleman here, Dr. Jay Yadav, he's the founder and the CEO of Mirus Medical, which is based outside of Atlanta. He was actually born in Meerut. And at the age of 10 years, his parents migrated to United States. He was a very bright student from the get-go. He worked with Dr. Gary Rubin in Alabama and was really the pioneer for carotid stenting. He essentially started carotid stenting and came out with AngioGuard and sold that to Johnson & Johnson. Then he invented CardioMEMS while he was a leading interventional cardiologist at the Cleveland Clinic. So when he was doing a lot of carotid work, all the interventionalists from all over the world were actually coming to him to learn about carotid stenting. There was this gentleman, Saul Siegel. Saul Siegel was from a very poor family as a kid and really hardworking, but always a business-oriented guy. So he grew up as a very successful businessman, had a lot of industries. And he developed a carotid disease, and obviously he finds out, like, where can I go get my carotid stenting? Goes to Cleveland Clinic, gets treated by Jay with a very nice result. Does very well, they become friends. Saul Siegel actually buys a house in Cleveland, starts living in Cleveland. And during their friendship, Jay would complain to him like, hey, you have metal industries. We need better alloys in medicine, because what we have right now is we have nitinol and we have cobalt chromium. Both of them have nickel. They're not very biocompatible. They don't have a lot of strength, so they have issues. So Saul Siegel said, why don't you go talk to this team of one of my companies and see what they can help you with. And the team introduced a new alloy called rhenium. Rhenium at that time was used by NASA for space rockets. The nozzle of the space rocket is made of rhenium. And they said, look, this is a very, very good alloy, and we think it can be biocompatible, so let's work together and refine it. And it turns out this is twice as stronger than cobalt chromium. It's more durability. There is less recoil in this, zero nickel, and it is very radiographically visible. So this alloy is now used in spine and orthopedic surgeries. There are over 30,000 implants with this alloy in the United States. It has not only CMS approval, but NTAP. NTAP means there is an additional payment for really high quality products. So this rhenium was being developed. In that meantime, Mr. Siegel develops aortic stenosis. He had peripheral arterial disease, wasn't a TF candidate. He gets enrolled in the partner trial's transapical arm. So at Cleveland Clinic, he gets a transapical sapien. The first valve embolizes. They put a second valve, still embolizes, put a third valve in. Ultimately, long hemodynamic collapse. He gets anoxic brain injury, never woke up. This picture right there is actually a week before his Tavr. This little kid is actually one of Jay's son. They were very close friends. So Mr. Siegel actually passed away from a complication of an alternate access Tavr. So Jay and his company are dedicating this valve to this great human being who's not only a philanthropist and a successful businessman, helped come up with this rhenium alloy, but also died from a massive complication of Tavr. So that's the human touch, to give you a little bit of background. So how am I associated with this? So talk about destiny. So Dr. Call in 2019, just before COVID, recruits me to Atlanta. This is a map of Atlanta. Just like Delhi has ring road, this is a ring road of Atlanta. So Piedmont is just right in the center. And about 30 minutes drive north is Mirrors. We're making spine surgery and orthopedic implants. And then if you read about all the valve flow dynamics and everything, they're all done at Georgia Tech by a professor called Ajit Yoginathan. Ajit Yoginathan is now retiring. Prasad Dasi, who we heard about in the earlier presentation, moves from Ohio State to Georgia Tech right around 2019 when all this is happening. And Jay comes up with this idea, okay, enough of spine. I'm an interventionalist at my heart. Let's make a valve. We get together with the team. And how does Gurgaon come in? A lot of the computer simulations of this Siegel valve that I'm about to show you have been done in Gurgaon. There is a Mirrors office in DLF, and where a lot of the things were done. And actually, when the valve goes commercial in a couple of years, it will be manufactured at a few different facilities, and Gurgaon will be one of the facilities for some part of the valve manufacturing. So here is the valve. It's a balloon expandable Tavr. It's made from this special alloy, rhenium. It's completely nickel-free, zero nickel in it. It has a nitric oxide coating on top. Think of it like a drug-eluting stent. In the coronary world, we have 5-year data that nitric oxide eluting stents are just as good as drug-eluting. Why were they never pursued? Stents are so cheap, there is no point of doing any more research in coronary stents. That's why it never took off. So we're putting nitric oxide on this Tavr valve, hoping that it will reduce inflammation, reduce halt. That's hypothesis that needs to be tested. It has a very fuzzy PVL skirt. It has commercial alignment flags that are inbuilt on the frame. And the leaflets are dry porcine anti-calcification treatment. And this valve is actually crimped onto the balloon, and it delivers through an 8-French expandable sheath for all sizes. 23, 26, a 29 millimeter seagull goes through an 8-French expandable sheath when it's preloaded on the balloon. So when you look at the traditional valves, they're closed in design. What closed cell means, the diamonds, these are diamonds. So the issue with diamond is that yes, it gives you strength, but as you expand, they shorten. That's why all the cobalt chromium cells like Sapien, when you deploy them, they foreshorten. Now, when you have a stronger alloy, you don't need closed cell design. You can make an open cell design, which is what the Seagull valve has. And it actually has vertical rods. So the crimped length to the deployed length is exactly the same. And because the crimped valve is smaller, you don't need a long balloon. So you'll have less balloon in LVOT, so you'll have less conduction issues. And that's the delivery system with the E-sheath. These are the CTs and fluoro of the 5 first-in-human cases that we did in Chile. See how circular the valve is. There is no waste. Typically, we don't see that straight frame in Sapiens. So the early feasibility study is ongoing right now. The first 15 were done, and now we're recruiting the next 15 in the EFS at 5 sites. Up to 10 sites will be invited. So this is a typical case example, 81-year-old, calcific aortic stenosis, calcium scores little over 2,000. Here is a valve implant. This was one of the earlier cases, so we're just trying to learn the procedure at that time. But you see, look at the bottom of the frame, it really doesn't change its depth. It does not foreshorten. Look at the root shot, no PVL, very low gradient, mean gradient of 3, essentially 0 by cath, and aortic valve area of 3.8. And I'll show you some of the EFS results in a little bit. This is a severe nickel allergy patient who was turned down from 2 different centers in US, ultimately came in, was enrolled in the study as EFS. 23 millimeter valve was deployed. Excellent hemodynamic gradients are 3 to 5 for these cases. And this is like a regular balloon expandable Tavr, so it doesn't increase your procedural time. This is a cardiac MRI. Look at the left image. See how high the valve is implanted. Really doesn't interfere with the conduction system, and the valve opening is preserved. The flow is very, very laminar. This is Dr. Makkar's case from Cedars-Sinai, LA. Actually, this was his very first case, and see how nicely you can precisely nail this like a coronary stent. 90-10 deployment, no PVL, low gradient. I'll show a very quick one more deployment just to give you a sense of how you place this valve. You really don't have to worry about the foreshortening. You can be very precise with this. These are the first 15 cases done in the EFS, all 90-10 deployments, very high deployments, all commercially aligned. Predilation was done only in a third of these cases, only because when you go to a new site and you see a gradient of 50 or 60, they say, well, this is a new device, I don't know, let's just predilate gently with a 16-18 balloon. Our intention is that with this valve, you should not need pre or post-ill as frequently as you need for other valves. These are the 30-day outcomes, essentially no issues early on, just one left bundle. Till date, 24 cases have been done with Seagull valve, 0 pacemakers, including patients with membranous septum of 0, including 91-year-old with bifascicular block. There are 3 upcoming cases with right bundle branch block. And this is the most fascinating slide where you see a gradient, where an aortic valve of 2.8 centimeters square. No surgical or transcatheter valve has ever shown this gradient. Makes you wonder, why is that? Well, how is the aortic valve area measured? You have to measure the LVOT diameter. Where do we measure it? At the bottom of the stent frame, outer edge to outer edge by the ASC guidelines. And we know the LVOT is not a rectangle, it's conical. If you deploy a little bit lower, even 2 millimeters lower, the LVOT gets narrow, the stent doesn't get expanded, you get a smaller diameter, gives you a smaller aortic valve area. Then you have a stent that has no foreshortening, so every single time you're going to land this 90-10. And then look at the recoil. The blue line is, the recoil is much less. The blue line is I think it's the Sapien, and then you have the Siegel valve, which has much less recoil. And the valve is circular, so you don't lose any energy from that waste that we see with the cobalt chromium frame. So in summary, there are excellent short-term outcomes. The first in human cases have reached 1 year. They all are doing very well. Very good 30-day EFS outcomes. Ease of use, it's an 8 French delivery, no foreshortening. Its commercial alignment is inbuilt, and it has very, very good hemodynamics, all this nickel-free, and nitric oxide. We'll see if that brings a pro-healing concept to this. And all-risk pivotal trial is going to start this year. This is the final image. Janar is a very good friend of mine who is visiting from Vancouver. The next to him is Dr. Bill O'Neill, who trained me in Detroit. He was visiting us. This is just a couple of weeks ago. We did 4 Siegel valves. We were done by 11:30 with the 4 cases that day. Right behind me is Vinu Tarani. He's a well-known cardiac surgeon. He's my surgical partner. And to the very right is Jay. So I'll stop there. Thank you very much.
Thank you, Pradeep. I remember in one of the meetings, Alan Krebier was asked, this was about 15 years ago, what do you think will be the holy grail for TAVI? He said, surgical-like results, less pacemakers or no pacemakers, no paravalvular leaks, and a gradient as good as a surgery. Have we reached that holy grail?
I think this valve will bring it, and I'll tell you what Dr. Mardiglian said when he was looking at some of these valve design and earlier. He said, this brings my Tavr dream to fruition. This is what I wanted to see before I retire. And he was very, very excited. He's deeply involved with the company in a non-financial way, in a more, he'll be the chair of the pivotal trial when it starts. So I think we are reaching that with these next generation devices. Because not only we are playing with the leaflets, now we're starting to play with the frame.
A surgeon's perspective, I think this is a great, thoughtful jump in the technology. I would have one question. What made you select porcine when bovine probably leaflets and all those things in surgical as well as Tavr group has shown very good results?
Yep.
I think whether those 3 leaflets are from different valves or one valve has been sewn like a freestyle.
It's not a one leaflet. These are porcine leaflets that are cut and then hand sewn. They're treated dry. Correct. Yeah. And the thickness is thicker than the Evolute, so they're not exactly like Evolute. They're a little bit thicker, but thinner than Sapien leaflets.
But why not bovine?
You could use either one. I think one reason is to conserve space. If you want to make the delivery system smaller, it's a little bit easier.
Ravinder?
Pradeep, congratulations on this. I think this is going to be a revolutionary technology once it comes into practice. One question, how do you coat nitrous oxide and how is it, does it elute slowly and what happens to it?
Yes, so it's a similar concept like a drug eluting. The reason you cannot use drug is because these are bulky stents. Your drug elution in the system will be at a very toxic level. So you can't use the regular coronary stent type things. The coating is about the same. How long does it stay in the system? How long, that is yet to be studied.
Prashant?
Yeah, so just one quick question. It's an 8 French expandable. So how much French it's being expandable?
So the marketing answer is 6 French smaller than Sapien.
Okay. So means the 14 French Sapien expand up to 18 or 20 sometimes. Because
so 14 goes to 22.
22.
So this will be 16.
16 French.
Correct.
So you need a vessel size of how much? It's around 5?
So in the trial, because it will be a pivotal trial randomizing against Sapien and Evolute, we'll have to follow their IFU. So in the trial, we're going to say follow their IFU, so 5.5 millimeters for Sapien and 5 for Evolute. But once the trial is done, then we're going to do a study, but more likely it's going to be around 4 millimeters.
So usually when you do the closure for these patients, the sheath, so do you go with just one ProGlide or
Yeah, you can, but in a trial, you don't want to introduce too many practice-changing things because then you have vascular complications. So is it because the mirror sheath is bad, or is it because you want per close? So I think in the trial, we want to keep all things similar. Just use your standard closure technique. Don't change too many things. Later on, you can always say how small can we go? Can we use one ProGlide? Is it one angioseal, manual pressure? All those down the line.
I was joking, Prashant, this valve will bring manual pressure back into practice.
Thank you very much. Thank you, Pradeep, for such an excellent presentation, and we're all looking forward to these newer valves. Yeah, so we'll have more discussions at the lunchtime, so we are closing this session now because we have to move to the next one. First, let me thank all the experts, moderators, and chairpersons for such a wonderful job during this session.